Well, good morning, everybody. Welcome to today's media call with the Association of State and Territorial Health Officials. I'd like to thank you for joining us on this meeting. My name is Marcus Plescia. I'm the Chief Medical Officer at the Association of State and Territorial Health Officials, and I'm here to kick things off and introduce our speakers who will be giving you some short presentations and then available for questions and answers. As you know, we're here to talk a little bit about the respiratory virus season that's coming up on us, or pan-respiratory disease, as we're now calling it. This is a good time to start talking about and preparing the public for this situation, as we're going to begin to see cases very soon. And as everybody knows, in addition to influenza and COVID-19, which I think most of the public is familiar with, we're also now in a position not only that we're more aware of RSV, respiratory syncytial virus, because of our situation last year, but we're also in a much better situation to deal with RSV. So with that said, we hope to have 3 of our state health officials from across the nation speak a little.
Marcus, you're on mute again. Can you just unmute yourself?
Okay.
Sorry, you've been remuted.
I think we continue to lose Marcus there.
Can you hear me now?
Yep.
Okay. So I think I was in the process of introducing our speakers. Let me just do that. First off, we're going to have Ann Zink, Dr. Ann Zink, who's the ASTHO president and who's the chief medical officer of the Alaska Department of Health. Next up, we're going to have Manisha Juthani, Dr. Manisha Juthani, who's the commissioner with the Connecticut Department of Public Health. And then finally, we're going to have Dr. Joe Kanter, who is the state health officer with the Louisiana Department of Health. I'm sorry, I'm dropping my words. So anyway, I'm going to hand it over to Dr. Zink to begin with, who's going to give us a little background on this issue, and then we'll pass it on to the next speaker. Thank you.
Great. Thanks so much, Marcus. And thank you all for being here on this morning to touch base on an incredibly important issue. We are all watching closely the respiratory season. It's something that state health officials are always preparing for every fall, particularly this fall with a couple major changes. So I'm just going to highlight some of the trends that we've seen with RSV, influenza, and COVID, a couple of tools, and highlight a few things in Alaska and hand it over to my partners. And we really look forward to your questions at the end. So as we all know, flu continues to circulate. We're watching closely what's happening down in the Southern Hemisphere right now. Last year, we saw over 9 million illnesses, 4 million medical visits, 10,000 hospitalizations, and 5,000 deaths are associated with influenza. However, we did see that vaccine prevented 1.8 million of those illnesses, 1 million of those medical visits, 22,000 hospitalizations, and 1,000 deaths. Particularly those who are less than 5 and those who are over 65 are at high risk for influenza. Everyone over the age of 6 months is eligible for influenza vaccination. And so I want to just highlight those who are less than 5, those who are greater than 65, and those who care and interact with those who are at risk are really the ones who are most at risk for getting influenza and are going to benefit the most from vaccination, and want to highlight to make sure that every American has an opportunity to get their vaccine before the end of October. As Dr. Plescia had mentioned earlier, RSV is a virus that's been circulating for a long time, but the impacts of it, I think, have been more appreciated by healthcare individuals as well as public health individuals this past year as we had more testing for it. Our estimates are hard to get because it's not always a reportable condition in every state, and we're seeing states, including Alaska, changing its reportable conditions, including using some of the IT infrastructure that was built during COVID to have a better sense of the respiratory illnesses that were there. We see annually about 2.1 million visits for just children less than 1, with somewhere between 100 to 300 pediatric deaths in those less than 1. But we also know that it impacts older adults, seeing somewhere between 60,000 to 160,000 adult hospitalizations a year, with an estimate of somewhere between 6,000 and 10,000 adults who die of RSV every single year. We're incredibly excited to see an RSV vaccine on the market this fall for those greater than 60 in thinking about risk benefit in combination with their primary care provider, as well as a longer acting monoclonal antibody to protect those who are youngest from this disease. And then COVID-19, we continue to see COVID. It continues to spread and be around. From February 2020 to 2021, 2021, we saw 146 million illnesses, with 124 million symptomatic patients, 7.5 million hospitalizations, and 921,000 deaths across the country. We are anticipating a flu booster and just want to continue to get out the message that testing, treating, and vaccinating can make a huge difference for COVID-19, particularly those who are older and at risk. Here in Alaska, as mentioned, we're using many of the tools that were developed during COVID-19 to make sure that we're able to share data between our healthcare partners and our public health partners to have a good eye on what's happening with these respiratory viruses, to make sure that we have hospital capacity and make sure that every Alaskan has opportunity to be vaccinated, to test if they're symptomatic, and if treatment's available, have access to timely treatment. And with that, I'll pass it over to Dr. Juthani.
Thank you very much, Dr. Zink. So I wanted to give a brief update about Connecticut and let you know that we too are preparing for this respiratory viral season and getting ready to be able to vaccinate as many people for flu and COVID as is indicated going forward, and as well as the new RSV treatments, vaccines, and therapeutics that are available to try to prevent RSV. So some of the things that we have seen in Connecticut is that we are preparing for our children going back to school, looking at immunization rates across the board. And we just released our 2022 immunization rates for school-age children. And we have seen a bump overall of 1.5% in an already highly vaccinated childhood population. But this last year was a time period where we were able to catch up on a lot of the vaccines that were behind for school-age children. Overall, seeing our highest bump since 2012, which is when we first started collecting such data. We did also have a religious exemption law that had been put into place. Our medical exemption rates have stayed the same, but even despite that, our immunization rates overall have gone up, and that law was upheld recently. And so we are continuing our efforts already in a community that is very interested in getting vaccinated overall. We understand there are those that have their reservations, but overall, the state of Connecticut has been doing these efforts and children are getting vaccinated and staying safe in school. Just to talk a little bit about the ACIP recommendations that have come through in these last several months. The immunization for RSV for adults age 60 and older is something that's been approved, and it's something that older adults should discuss with their primary care providers to see if it would be a good idea for them to get vaccinated. I think for our youngest children, there is potentially a maternal vaccine for RSV that may come down the pike, but right now it is not ready yet to be approved. But what has been approved is a monoclonal antibody for our youngest infants. What it's really being recommended for is to be administered to children in the first week of life. And this is to prevent hospitalization, which RSV for our youngest of young children is the most common cause of hospitalization, so potentially can prevent morbidity and mortality in those patients. So that is the medication, which is going to be administered sort of in the same kind of concept of vaccines. Hopefully this season we'll see a start to that. Exactly how that's going to roll out, we're still waiting to hear a little bit more, but the first step was for that to be approved. And so that has been the most recent recommendation from the ACIP. With that, I will turn it over to Dr. Kanter.
Thanks so much, Dr. Juthani. Good morning, everyone. This summer is flying by. As we think ahead to the vaccine campaigns in the fall that are on the horizon, one of the comments that we have begun to hear is that this is a lot. And I understand that comment. I want to tell you how we're thinking about it on our end. Largely, this is a simplification from the vaccine recommendations of the past few years with an added protection that's available to some of the most vulnerable people in the country. It's a simplification because on the COVID vaccine front, we will now likely have one vaccine shot that's going to be recommended every year. That's a simplification from random boosters that have been recommended at various times, prompted by the changing variants of COVID. So we're looking forward to a much more simplified regimen, and that's what's coming down this fall. For the added protection, as Dr. Juthani mentioned, RSV every year is a cause for morbidity and mortality of some of the most vulnerable people in the country, some of the youngest and the oldest. We've had poor defenses against that up until now, where we have good protections for, again, people that the most at risk for this virus. I'll tell you, one of the things that we internalized during the COVID pandemic in thinking through how we deal with other common viruses like flu is we have just accepted amount of mortality every year from viruses like the flu. For example, in Louisiana, every year about 1,000 people die from the flu, and a handful of those people are kids. In years past, we've simply accepted that, almost like the cost of doing business. COVID made us realize that when you have protections out there, you should do your best to make sure they're utilized, because those lives can be saved. That's how we think about RSV. As Dr. Juthani mentioned, every year, 100 to 300 kids die from RSV. With the protections that will be available to us soon, we can greatly decrease that number. And that's going to be our goal going forward. Here in Louisiana, we typically have done very well with routine childhood vaccinations. Usually 96% of kids are vaccinated by the time they enter kindergarten. Although through the pandemic, that number has been slipping a little bit, and now we're at 94%. To us, that's a wake-up call and a call for action. And we're doubling our efforts ahead of the back to school season with earned media, paid media, and really getting the word out, putting physicians and caregivers front and center to encourage and lower barriers to families getting vaccinated. But it's important to note that although we've seen that number slip a little bit, 94% is still a very big number. It's an overwhelming number. There's not a lot of things in this country that 94% of people all do. So when we think about the issues with vaccines, let's remember that the overwhelming majority, the vast overwhelming majority of Americans take advantage of the protections that vaccines provide for their children. One of the other lessons that we learned from COVID is that you can't wait for people to come to you. You have to really make an effort to go meet them where they're at. So as we look to the back to school season, we are leveraging one of the more effective programs we had during COVID, which is bringing vaccine out to people. We have teams of vaccine strike teams that we instituted during COVID that we're now leveraging for flu and RSV to go out into the communities and host vaccine events at convenient locations for families. Over the past few years, we've done this at over 1,300 locations, over 2,500 discrete events, and we've given out 44,000 vaccine doses in the community. And a number of those were at homes for homebound individuals. We're going to continue those campaigns because we know we need to reduce barriers wherever we find them. And if we can help bring vaccines to people and avoid the necessary hurdle of coming to a pharmacy or a physician's office, we're going to do that because our families benefit from that. So that's going to be one of our main strategies going forward. In closing, I'll just mention this. Vaccines are in the public discourse in a way they just simply were not years ago. That's something that we have to accept. It's going to be an evergreen issue for us to maintain conversation about vaccines, and most importantly, ensure that the information out there is factual and health-based. We're going to do this every year because our families deserve to get the most accurate information about how to protect their children. Dr. Plescia, I'll turn it back over to you.
Great. Well, thank you very much to all the panelists for a really great overview of what's going on. I'll just summarize a couple of things. We are very, very concerned about the upcoming pan-respiratory season. And I think what you heard from a number of our speakers are wanting to really make the public aware of the significant toll that RSV has played in our society in past years. I think a lot of people have not been aware of that, and there's an enormous impact on very young children, infants as we call them, and on adults who are in their older ages. And we can now prevent hospitalizations and death in those age strata now that we have these new RSV vaccines and therapeutics. You've heard quite a bit about how everybody is getting ready for this fall session, and that we do have tools, and we have tools that are simpler and that are more effective. And I think that Dr. Kanter kind of summed it up well. Lost lives are no longer a cost of doing business today. We're not going to tolerate that. We're really trying to move forward to the fact that that's not the case for these respiratory illnesses we have a very strong armament of different modalities we can use to take them on. So what we'll do now is open the floor up to questions from our reporters. And I think we've notified you, you can just go into reactions on the Zoom board and raise your hand. And I see we have a couple of hands raised. Stephanie, should I just choose, or are you going to choose one?
I think we're going to try to go in order. So Fran, Kritz, I'm going to unmute you. I believe calling in from NPR today. If you want to introduce yourself and go ahead.
Hi, it's Fran Kritz, working on a story for NPR. Thanks so much for doing the call. My question is for Dr. Juthani. I wanted to ask whether there's concern either among physicians or among people thinking about COVID boosters, that at some point there'll be diminishing returns if they get too many. So as we're headed toward a potential updated booster, and even as some people are considering a booster now, if they are eligible and haven't gotten it yet because of the rise in cases, whether there's either consumer concern or physician concern that at some point we'll be getting boosters and vaccines for COVID-19, but that it won't still help us.
Thank you for the question, Fran. You know, I think one of the things we've seen is that people have had some fatigue over these last several years, but for many people, they have not had a COVID shot in a year or maybe 2 years now. So we know that our booster last year had limited uptake. And for many people, they might not have had a COVID vaccine in quite some time. And we know that a lot of people line up to get a flu shot every year. And at this point, it does seem like the indications are that a COVID shot potentially on a yearly basis, particularly for our oldest age groups, is going to be what's going to help them stay out of the hospital and potentially prevent death. So I do understand that people are feeling this, that they just feel like there's been so much messaging around vaccination, and a lot of people have also had COVID. We do know that having had COVID and a vaccine is probably the most protective you can be in terms of preventing some of those most serious outcomes. But what I would say to people is that we know that we do this for our children to protect themselves, to protect our society at large, particularly for our oldest age groups, to maintain your quality of life, to stay out of the hospital, to be able to continue to enjoy the holidays that are upcoming. Think about that. Think about the fact that Thanksgiving is not so far around the corner, that you've got Christmas and Hanukkah and other winter holidays, New Year's coming up when people want to spend time with their friends and family. And we've just been through 3 years of a lot of this, but on the other hand, when you need to be separated from people in times that you really want to be together, the best way to do that is to be safe, and keeping your eye on that end game and that particular goal, I think, is something that will motivate people overall to help protect themselves and their families.
Thank you.
Great. Next up, we have Erika Edwards. If we could unmute Erika's line.
Hey, good morning. Thanks so much for taking my call. I have a question and then a follow-up to Fran's. Number one, is there anything you can say about this new EG.5 subvariant and its potential impact on what's going to be happening with COVID this fall? And then just to follow up on Fran's, is there any evidence yet about how long these boosters, the effectiveness of these boosters will last? That is there sort of a sweet spot when it comes to when to get that booster shot if we only have one this fall? Thank you.
Joe, you want to take a shot at that one?
Yeah, I'll go ahead and start. So, you know, EG.5 is by a sliver the dominant variant in the US right now. Although I will say this is the first time in a while that visibility on genomic variants is a little bit less, because formal testing has gone down. There's actually not enough sequencing being reported to the CDC to do their nowcast on every region of the country. So we have a little bit less visibility, although we expect EG.5 to continue to grow in prominence and become even more so the dominant variant. You know, the expectation is that the updated monovalent boosters that will become available in the coming 1 to 2 months will retain good activity against EG.5. Those boosters are based on another Omicron subvariant XBB.1.5. The EG.5 variant that's growing now is an Omicron variant. It's a cousin. And it's not that different from what we expect. So we expect there to be good coverage. In terms of the longevity of protection, it's really difficult to predict. You know, this virus, COVID, mutates quite quickly, as we've seen. And there always could be curveballs. I think the way that we think about it is, you know, when you have protection available to you, you're best off to take that. Can't tell you exactly how long, how many days precisely that will last, but if you don't take that, every day that after that is a day that you're vulnerable. And for people that are more vulnerable to severe disease, it's even more important. So we're looking forward to the booster becoming available, and we hope to make it available to people that really can benefit most from it.
Great, thank you. Next up, we have Yuri Benajud.
Hi there, thanks for taking my question. Yuri from ABC News. I'm just curious if there's any indication as to how severe this upcoming winter season is going to be, just based on what we've been seeing in the Southern Hemisphere in countries like Australia. Thanks.
Anne, are you up for that one?
Sure, I think we can all chime in. We're watching closely what's happening in the Southern Hemisphere, and I think that Dr. Kanter summarized it well. We're really excited for the tools that we have, but there can be curveballs, and it's hard to know how those curveballs are going to come at us or what's going to change. But currently what we're seeing in the Southern Hemisphere is a lot of cases of influenza. However, no significant variant changes, and the vaccine is prepared to better be a good match according to what we're seeing in the Southern Hemisphere. So in general, we're expecting a decent number of RSV, COVID, and influenza cases, and why we're taking this time, particularly during National Immunization Month, to get out the word to make sure that every American has a chance to get vaccinated, have the protection, as well as have an opportunity to test and treat coming this fall season. Because just as Joe Kanter mentioned, we have a little bit less visibility with some of the previous tools that we had in the past, but we still have fairly limited healthcare capacity in our country, and want to make sure that Alaskans, Americans, and everyone is able to stay safe and healthy.
Anybody
I'll just add.
else want to add?
Yeah, sorry, Marcus. I was just going to add a couple other thoughts, which is that, you know, I think for influenza, we have these tools of looking at the Southern Hemisphere and sort of knowing that that's going to be somewhat of a prediction of what's going to happen for us. And I think that with COVID, each year that we get out of pandemic restrictions and going back to normalcy of life, we learn a little bit more, and we're learning more and more potentially what that new wave may look like. I don't know that we know that exactly just yet. And I think one of our challenges is that last year was probably the closest to our first year of getting that information. What we saw with that is that we saw a rise in RSV much earlier than we would have expected. We saw children that had not been exposed have a rise in infections, and that really led to the surge in pediatric inpatient hospitalizations for children that had been protected for several years from routine viruses that they would see. So we've had 1 year of RSV, so to say, under our belt, circulating in a more typical fashion. So I think we're entering a season where we don't really know how these viruses are going to interact with each other. And so timing of vaccinations and how they're going to interact with each other is a little bit unknown. But what I would say for people is that we know that from last year and the data that we have, that COVID and flu vaccines can be given together if you are comfortable with that. You can certainly stagger them if you want to do that as they become available. And looking a little bit at what you hear, at least happening in your community in terms of RSV, would be a reasonable discussion to have with your provider, because every area of the country, when it comes to the rise in some of these viruses, is happening potentially at different times. We've been hearing of, slow rises starting to happen with COVID. People have been traveling a lot this summer. People are going to events this summer, and we don't have everything ready to administer right now. But some of these discussions can start happening, and you can start thinking about how you might want to get these vaccines over the next couple of months and especially for our oldest age groups where RSV may be available to them, and for newborns that are being born when that RSV vaccine comes to play. Because I think for the newborns, that's where our signal is definitely the strongest, that we have something that can potentially protect newborns from RSV.
And to add a little bit to that, I completely agree with Dr. Juthani and Dr. Zink. I think it's important to be honest with the public, but not overly alarmist if not necessary. We've had 7 surges of COVID in Louisiana. The past 2 of them have been accompanied by a lot of transmission of virus, but not a lot of clinical acuity, at least not compared to prior surges. And that's in part owing to the fact that this is no longer a novel virus. At this point, for example, in Louisiana, 95% of the state has either had COVID, been vaccinated, or passed, and that does confer protection to us. Our expectation with this coming surge is similar, that there'll be transmission, but not necessarily acuity in the volume that will overwhelm our hospitals. That's our expectation. That's our hope. That said, 2 points. One, we're still going to be ready. And so we're still preparing like we would any fall for what could be a busy flu season. So we still ensure our hospitals are ready and that they're prepared should that surge and acuity exceed what we expect. And number 2, that doesn't mean that acuity is low for everyone. There still are people that are highly vulnerable. We still have not had a week in Louisiana where we've not reported a death from COVID. And so we know that people remain very vulnerable. So even though we're not expecting our hospitals to be overwhelmed, and even though we're clearly in a much better place with COVID, at least, than we were in the past couple of years, that doesn't mean that there are very vulnerable people out there. And so when there are tools out there, like an updated booster or like an RSV immunization, we want to make sure we're leveraging those as much as possible.
Great, thank you. So the order of hands keeps jumping around a bit on the screen. So the next 4 will have Fennett, then Lena, then Ken, then Jacqueline. So that's the order I've got now. So let's start out with Fennett Nirapil. We can unmute your line.
Hi, thank you for taking up my question. Do we expect these new vaccines that we have to actually protect us ahead of the respiratory season when you have all these unknowns up in the air, like the regulatory approvals and questions about whether you can be co-administering these shots?
I think the simple answer to that question is yes. What we do is we look at the science and data, and the FDA and the ACIP does not recommend them if they don't look like they will benefit Americans, that they will protect you from severe illness, hospitalization, and death. So we recommend vaccination when the data is strongly in favor, if not overwhelmingly in favor, of protection to individuals. In fact, vaccinations are probably one of the safest, if not the safest things that we do in healthcare on a regular basis, because we're administering them to otherwise healthy people and to large swaths of people. And so the data, the understanding, the collection, the safety, and the efficacy is impressive with vaccination. And while there's a lot of conversation about vaccination and vaccination safety, there's nothing that's perfect. These are incredibly safe, incredibly efficacious, and why we are recommending them for those who are at most risk and those who are recommended depending on their age group. We've kind of gone through those. But Dr. Juthani or Kanter, other things you would emphasize?
I think I would just add to that, which I agree with everything Dr. Zink said, is that we know that co-administration of COVID and flu vaccines is possible, and we've already done that for a year, and we'll do that again this coming year. I think for RSV, for those that are recommended to get that in discussion with their provider, that may be one that may be better off doing separately. And so a little bit of staggering with that is something that could be done, but it also can be co-administered. It has been studied to say that it can be co-administered as well. But that is one of the things I would say that has come out with data. So I think to your question, we have information to answer that question. And I also think that one of the biggest points we want to drive home is that there is not a single vaccine that is going to be 100%. But having said that, the efficacy of these vaccines is so high in preventing some of our worst outcomes that that is the main thing we want to drive home, and that is going to make a difference in the overall health of a person who receives them.
Just a quick follow-up. Do you expect children's hospitals to be overwhelmed by RSV like they were last year?
Again, I'm happy to start on this question. As Dr. Kanter had mentioned, we are preparing for the worst while we're hoping for the best. And so we're working closely with our hospitals, including our pediatric hospitals. As Dr. Juthani had mentioned earlier, we also see large regional variation on all sorts of respiratory illnesses. I work in Alaska, and we're quite far away from Dr. Juthani. And so our pediatric hospitals can become very overwhelmed in a short period of time with hours, if not days of transport. And so I think that it's really important to stay tuned to your local health officials' news and information. In fact, when COVID-19 first kind of came on in 2020, we were experiencing one of the worst RSV seasons that we had ever seen. And we're deploying pediatric hospitalists to some of our most rural and remote regions. And we were running out of pediatric ventilators at that time for our PEDS cases. So this is something that state health officials and local health officials have been dealing with for years. I think there was more national attention with COVID-19, and we will see what happens this fall season, but really staying tuned to local health information as we see these respiratory seasons merge, as we see them come up in different regions. But I would suspect that we have regions that do become stretched with the hope that we don't see an overwhelming burden on our hospital system like we did in COVID-19 in the first year.
Other comments on that?
I think I'll just add one other comment, which is that one of the challenges last year is that RSV started earlier for us than we normally see RSV. And again, because so many of these children had been protected for a long period of time, many of them had not been exposed to RSV the way they may have been in normal childhood development. So I think last year was a little bit of an anomaly for that reason. But again, having said that, we're in uncharted territory. We don't really know what this season is going to look like, and it's going to look different in different areas of the country. So one of the things we are doing in Connecticut is meeting with our children's hospitals, understanding what their plan is going to be for if we see a surge starting this fall. And honestly, we're here to talk about vaccinations, but from a pediatric perspective, we're looking at it from both a perspective of ICU and other respiratory viral diseases, but also behavioral health, because that is one thing we saw a confluence of in our children's hospitals last year. And so this is the type of planning that happens at the state level across the United States. And I'm just speaking for Connecticut, but it is that planning and preparation and discussion of what we're going to do if we see something that we can anticipate, or it's to the best of our ability for something we cannot anticipate.
Great. Let's move on to some questions from Lena Sun.
Hi, thank you for doing this. Can you hear me?
Yes, we can.
Could one of you, perhaps Dr. Zink, talk through the nuts and bolts process of, if I'm a consumer, how am I going to be getting this year's COVID vaccine? Because the government is no longer purchasing, it's no longer pre-positioning the vaccine. Once ACIP and CDC sign off, what do you expect that the next process to look like? Will hospitals then order from the manufacturers? As me as the consumer, will I have to rely on CVS and Walgreens to order? That's going to take time.
Yeah, thanks, Lena, for the question. And unfortunately, your question is nuanced, and it very much depends on the state and the local entity. So different states are doing different things. There is the Bridge program, which we're excited about from the federal government to try to make sure that there is more COVID-19 vaccination available to those who don't have access to insurance and don't have easy access. But how states are doing that are really different. You heard a bit, Dr. Kanter's team, going kind of home to home and house to house. In the state of Alaska, we have very few pharmacies and very few pharmacy partners. So we've never been able to rely heavily on pharmacy and pharmacy partners. Some states like Alaska have a large purchasing program. We have a program called AVAP, where we bulk purchase vaccine, both with state insurance as well as private insurance. And we merge that together with other federal programs, such as the Bridge program, to make sure that we are able to drive down the cost of vaccination to be able to get it out to more people. So this year in Alaska, we have included the COVID-19 vaccination as a part of our AVAP program, We are bulk purchasing in combination with the Bridge program. And then we are working with communities to see what's going to make the most sense. We're learning from what took place during COVID-19. So in some regions, having mass vaccination sites were really helpful. Drive-through came up a lot during flu, but then was really highlighted during COVID. People didn't want to get out of their car. They wanted to be able to drive through on their way home to work. And I think that it's really important what you mentioned in just the access component to it, because there's a lot of individuals who are fine getting vaccinated, but they don't have time between their jobs and picking up their kids from school and going to work and all of the busy things that we are all doing. And so part of the work that we're doing as state health officials is to try to make it as easy as possible for individuals to make sure that they are able to get vaccinated, be it in their healthcare provider, be it in their pharmacy, be it in their grocery store when they're picking up groceries, or a drive-through. But I know from at least Alaska, I'd really encourage local entities, if they have a new idea or something else that they think is going to work for their community, we are all ears. We are still trying to innovate and trying to make sure that it is not a barrier for people to get vaccination with their time and distance. And again, bulk purchasing to make sure that anyone, regardless of insurance type, is able to get it. I know, Dr.
Can I ask
Yep,
can I ask a follow-up? So
Yeah.
among the states, how serious is the discussion about having drive-through and mass vaccination clinics? Because last time during COVID, the federal government paid for a lot of that. This time, the vaccine is commercialized, right? So then the states would have to do it, and you guys don't have money.
Yeah, the funding is different. And last time there were a lot of drive-through federal sites, particularly in large urban areas. In smaller rural areas, those were not available. And so we relied on local hospitals or others to do drive-through clinics. So I think it's really different depending on the state and their capacity. But in general, I would say that a lot of states are thinking very creatively about how to get out vaccination, and including mass sites as well as drive-through sites. But it's very different depending on the state as well as how the vaccination happens. So for us, drive-through will be a part of our fall vaccine effort, as well as mass vaccine sites for sure. But I don't know if Dr. Kanter or Dr. Juthani have more insight into their states that they want to share.
Sure. Yeah. Thanks, Dr. Zink. And thanks for the question, Lena. The federal government is purchasing COVID vaccine, just not for everyone. They're making a much smaller purchase, typically aimed at underinsured and more marginalized individuals. I think it's up to each state and local health department to figure out how to best connect that to the people that are most marginalized and needed. I'll tell you, in Louisiana, we're going to leverage community vaccine sites, maybe not drive-throughs, but smaller vaccine events, deeper in the community, in churches, in community centers. We've had a lot of success at those type of events, particularly at locations that people already trust, that they have a pre-existing relationship with. That's what we learned out of COVID. That helped us a lot with our equity challenges in COVID, and that's what we're going to leverage going forward. I would think each state has a strategy of how to connect vaccine to the people that need it most. For the majority of Americans, though, most Americans have good access to flu vaccines, for example, through pharmacies and through other avenues. We knew that commercialization of the COVID vaccine was coming. It was well broadcast. It certainly wasn't a surprise. It's part of normalizing our response coming out of the emergency. So this was not anything that caught people on the heels. And I think our ultimate goal is to make it as accessible as flu vaccine, which for the majority of Americans is very accessible.
I think the only other thing I would add is that, the response that we have now is different than the response when this was a completely novel virus and there was no really sizable immunity in our community. And now, given that we do have a lot of vaccination coverage, at least historically, and infection that's happened, and we have been signposted that this was going to be commercialized for a long period of time, each state is going to leverage their resources that they always leverage to be able to reach our most marginalized communities. And we're expanding that to include the COVID vaccine this time around. And the good news is we can see in the numbers that we've seen through the summer and even right now that our numbers are nowhere close to what they were 3 years ago when this was a novel pandemic. And so that is the good news. And I think that we want to leverage what we've learned in the past and build on that in terms of being able to incorporate COVID vaccine administration and treatment into our routine medical care.
Great. I think next we have Ping Huang.
Hey, thanks for taking my question. This is Ping Huang from NPR. I wanted to ask about how you're going to be tracking the epidemiology of the diseases and also the prevention services that you're offering this fall. Are you going to be using like wastewater surveillance to collect data? Is there required reporting for each vaccine? Like sort of walk me through what you're going to be collecting to sort of keep track of what's happening.
Yeah, it's a fantastic question, and maybe we can each go through it a little bit differently. So in Alaska, influenza has been a reportable condition, and we've always tried to keep track of every case that came into the hospital rather than estimates, as well as those that were tested positive in clinic. We have moved RSV to being a reportable condition as well, so that we have a better eye on RSV, because we've seen a disproportionate burden of RSV cases in the past, particularly in our most rural areas, communities without a lot of running water and sewer, and our Alaska Native population. And so we want to make sure that we have a better understanding of that. We always get this syndromic surveillance data that looks at influenza-like illnesses that show up in hospitals, but sometimes we'll see low influenza cases and high LI cases. So we know that some sort of respiratory virus is circulating, but we can't totally tell what it is. And so we're really excited to have RSV and influenza be two additional reportable diseases plus COVID-19 to have better detail on what those influenza-like illnesses are. And that will also help us keep an eye on new pathogens that we need to be an eye on. So if all three of those are low and we're seeing high ILI cases, we need to dig deeper and we need to know what that's looking like. So we're really grateful for a lot of the data modernization infrastructure that came through to states. We have a long way to go, but is allowing us to have better granular data on what is happening from an influenza-like illness or respiratory pathogen season, which is going to give us totally different ability to see what's happening in our state and be able to respond with either treatments or vaccinations or therapeutics or capacity. So we're excited for that. It's harder to see within the healthcare system for delivery for vaccinations. Again, as I mentioned previously, the state bulk purchases, we have one vaccination system. We have a tool now where individual Alaskans can download an app and see their own vaccinations in their own palm of their hand, which has really allowed people to be able to get vaccination information better to their school, but honestly better to their healthcare providers too. So we can see what they're up to date on or what they're not. So we're trying to really empower individuals with healthcare in their hands so that they can be an advocate for themselves and they can also be that connection piece moving back and forth. For us in Alaska, wastewater is not a huge part. Most of our community is on septic or sewer. And in fact, we're still struggling to get access to running water and sewer in 36 communities in our state. So wastewater is just not a really useful tool here. And it really depends on the individual states and why we're moving more towards reportable conditions within our healthcare facilities, including our clinics. But maybe I'll hand it over to Dr. Kanter next.
Yeah, thanks, Dr. Zink. Very similar situation in Louisiana. We're modeling reporting on what we've done for flu for many, many years, which has worked well. For COVID, we're going to be keeping track very closely of the highest significant cases, which are the hospitalizations, same with flu, and then doing more broad-based measures, more surveillance measures for the general population. Like flu, we don't count every case that's out there in the community. And that's becoming the case with COVID now too. The analogy that we've been using for quite some time now is you don't have to count every raindrop to know how hard it's raining outside. That's really the guiding principle here. That said, I will add, all states have built a very robust reporting infrastructure through the pandemic. And we don't expect this surge to be of the magnitude where hospitals would be overwhelmed like they were a couple of years ago, for example. But God forbid if it was, we would be easily able to open back up that reporting infrastructure to get more granular reporting if we felt like it was needed.
And I would just add in Connecticut, we also are doing similar things. We are doing sort of all of the above that you mentioned. So we are looking at wastewater. We continue to look at our numbers. So RSV, influenza, and COVID hospitalizations have been reportable in Connecticut, and laboratory tests are also reportable. So that's where we get a little bit of a view on what's happening in the community when even somebody doesn't get admitted to the hospital. So one thing, again, we want to let people know is just because we may not be reporting these numbers on a daily basis, we as a health department still continue to look at these numbers regularly. And we have more of eyes on this on a weekly basis, but we continue to look at all of those respiratory viral disease indicators that we have. In addition to that, as Dr. Zink mentioned, we have something called syndromic surveillance. This is the symptoms that people present to an emergency department with. Are there symptoms of an influenza-like illness, somebody coming in with fever, cough, body aches, things like that? And so that's where sometimes you get a view on something that might not be RSV, flu, or COVID. We will go back to reporting these numbers just like we do for flu every year, basically between October and May. And that is our respiratory viral season for when we report these numbers publicly. But between looking at the numbers, looking at wastewater, and continuing to follow vaccination rates, which we are able to collect through CT-WIZ, which is the reporting mechanism for vaccines that are administered in the state of Connecticut, we'll have a better sense of what's exactly happening in our communities. And as I mentioned before, we continue to partner with our hospitals to be able to plan and prepare for what we anticipate to be a respiratory viral season and look at whatever may be unexpected as we head into this fall.
Great. I think now we'll go to Jacqueline Howard, which is the last hand that I see up. We could probably take a few more if people have questions, but Jacqueline, thank you for your patience, and your mic is on.
Thank you for taking my question. I'm Jacqueline Howard with CNN. My question is, with the flu vaccine, we often hear the saying flu before boo. So get your flu vaccine preferably before Halloween. I'm curious, will there be any similar guidance for when exactly this fall people should get either their COVID booster and or their RSV vaccine if they're eligible? And so is there really like a recommended window of time this fall and winter for those other vaccines? And a quick follow to that question, do you plan on any media campaigns to really get the word out and encourage people to get vaccinated? Do you have the funding to do this? I know funding is different this year, so will states have the funding needed to release, ads, video campaigns, or do any of that type of outreach that we've seen in previous years? Thanks.
Yeah, maybe I'll start and hand it to Dr. Juthani next. So yeah, I love that flu before boo. So successful media campaign right there. We are anticipating for influenza the same messaging. So really getting your influenza vaccine before the end of October. So flu before boo, whatever that looks like in your state is fantastic. 2 for COVID-19. Our state does not have a great acronym to go with that one yet. So we'll have to think about some additional ones, but looking at this respiratory fall season and saying, this fall getting boosted. I think Dr. Kanter really highlighted the simplicity of it. And I think that's going to take a lot of messaging about the fact of how many, when should I, do I not need to, I had X, Y, or Z, and just getting into a little bit more of a regular pattern for getting updated for COVID-19. RSV is a little bit trickier, as Dr. Juthani had mentioned earlier. We're waiting on the FDA for one for people who are pregnant, but we do have one available for older individuals right now. And the big recommendation right now is to talk to your healthcare provider now if you're over 60, so that you can start to have that conversation with your healthcare provider for timing and figuring out what that looks like for you. I think as states, we are planning on messaging campaigns. We have been anticipating this data so that we can know what we're saying to be able to message it. So we'll continue to refine that. A big emphasis, I think, for all of us right now, though, is just back to school. And we know that that's when most of our children get vaccinated, is back to school in general. So a lot of us are in the middle of big back to flu campaign or back to school campaigns right now, making sure that they are getting vaccinated prior to school. And then we move right into the respiratory season. And I think you'll be seeing every state having slightly different vaccination messaging, depending on what resonates with that local community. I know that Alaska really tries to focus on Alaska specific messaging. You heard Dr. Kanter talk about local messaging from trusted healthcare providers. And so that messaging may be different, but we do have some funding to help to get out messaging. But Dr. Juthani?
Thanks, Dr. Zink. I think for many people, we really want to make this easy and simple. And for those that are comfortable getting co-administered flu and COVID vaccines at the same time, I don't think it's unreasonable to think of COVID flu before boo, because I think if you're going to go in once and you get both at the same time, I think that, the real thing is going to be, we need to see exactly what the recommendation is going to be. But if that is what's recommended, then I think keeping it simple for people where they can get both at the same time would be a very reasonable thing. I think the other thing just for us in Connecticut to reinforce is we do have funding to be able to support media campaigns going into this fall. We are planning to do that. We always really try to message back to school vaccinations, flu vaccines in the fall. That's going to be same and true for COVID. And RSV, again, because we just don't know exactly when it's going to be circulating in different communities, it does make it a little bit more challenging. That's why starting the conversation now is a reasonable thing to do with your provider, especially if you get that potentially sooner and then get COVID flu a little bit later in the season, maybe before Boo. Thanks.
And just quickly, I agree with all of the above. I wouldn't underestimate the importance of earned media here. A little bit less pertinent to the national outlets, but for local media, people love hearing from community healthcare providers. And there's a real need to get that information out there. And there's a real level of trust that can be leveraged. So we had a lot of success with that during COVID. And we're hoping to replicate that for the fall respiratory virus season, getting local healthcare provided trusted messengers out there, not only in the media, but also in the community, and let them be the voice. And one of the things that we have found, even amongst people that harbor distrust towards vaccines or distrust towards the health department, they still have a lot of trust in their own healthcare provider. And that's often the best messenger for these types of items.
Yeah, and I just want to reinforce, Dr. Juthani mentioned one of the messages we are hearing from federal partners is that it may be useful to go ahead and encourage people who are going to be able to get all 3 vaccines to go ahead and get the RSV vaccine. So if you're 60 or older and maybe at risk, go ahead and have those conversations. You could go ahead and get that vaccine now, which means then you'd only have the other 2 to get to ultimately get at those 3. So that's a good strategy and the kind of some information we want to get out there. I see that we have another question from Erika Edwards. So Erika, the floor is yours.
Thanks for the opportunity for another question. Talking about that timing, I guess specific timing of vaccines specific to people over age 60 who will have COVID, flu, and RSV vaccines. There's some evidence that maybe, they should not perhaps get all 3 together all at once. Adding that RSV vaccine might reduce the overall effectiveness. What's your current guidance on when this vulnerable population should get each of these 3 shots this fall?
Yeah, Erika, thanks for the question. Maybe I'll hand it over to Dr. Juthani next, who's been on our ACIP. I would also just add to the last conversation that we had. I just want to thank you all as national media outlets for being here and hearing this question. I was recently on the Yukon River, and it's a very remote and isolated place, but national outlets were the easiest place for them to get media and media information. So what was happening in Connecticut, they were very attuned to, and it was harder for them to stay attuned to some of the local media and information here. And so really what is portrayed on a national level can have a really big impact, even in their smallest and most remote places in the country. So I just wanted to thank you all for being here. Regarding messaging, I think it's a fantastic question. And I think a lot depends on someone's ability to access healthcare and the simplicity in their lives. And so if it's going to be challenging to access healthcare and they're super busy having that one-time visit, as you heard from Dr. Plescia as well as Dr. Juthani, there is benefit of having them, even if they're at all the same time, if that's the only opportunity. But if someone has the resources and ability to spread them out, there is some data that being able to spread them out could be beneficial to that individual and to better be able to time that. So that's why we've been saying for particularly RSV, talking to your healthcare provider now so that you can kind of strategize and talk about that. But again, the epidemiology looks different across the country, and we expect it to look different across the country. So if we have a very tuned in, very educated, older individual who's able to keep track of what's happening in your local community for those cases, and you've got access to being able to go in and get the vaccines at slightly different times, that's going to be the best protection. But no protection because of complications in life and schedule and the rest of it, having them at the same time is better than not having them at all. So not the simplest of messages, but we are really trying to make sure that the variety of people who have a variety of medical conditions and variety of access have access regardless, and would emphasize it's better to get them all at the same time than to not get them at all. However, if you've got the ability to spread them out and working closely with your healthcare provider, there can be some added benefit there. Dr. Juthani?
Yes, thanks, Dr. Zink. I think this is a little bit analogous to trying to time the market. If you want to be in the market and try to grow your portfolio. You want to get in. And if you're going to be too complicated in terms of your life with work and other things that you have going on where you miss out on the opportunity to get in, well, that's going to be worse. So really, ideally, I think the data does show us, and what we heard in the ACIP meeting is that RSV given separately from the other two may be the ideal. And I think that if you are able to have that conversation, if you're eligible for the RSV vaccine, and maybe you get that a little earlier in the season and then can get COVID and flu later, potentially even together, that may be the ideal. But again, having all three together is possible. It'll certainly be effective. It may be ideal to get RSV separately, but I think what we really want to see is that people have some level of protection going into this season. And I think one of the bigger challenges that we see with some of these vaccines is that we don't know when the surge in a given community is going to be. And as an older adult, if you have, let's say, a newborn in your life, a grandchild, if you have young children that you're taking care of on a regular basis and you want to be able to protect yourself going into this season, this is the type of thing that you may want to get done earlier, just so that you have that opportunity for protection. But if you're going to have one time when you can actually have time off to get into a doctor's office or get to a pharmacy or somewhere to get a vaccine, it's certainly very possible to get all three at once.
And I'll just add, as has been mentioned, it's never wrong advice to advise people to talk to their healthcare providers about these types of questions. The point of ringing the bell now is not to encourage people and go get these vaccines tomorrow. The RSV vaccine isn't even available yet. But the point of ringing the bell now, as Dr. Zink mentioned, is to put this on people's radars so they can have the conversations now, so they don't wait until Halloween to then talk to their doctor about what would be best for them. Everything can be individualized. The best advice almost always is to have these conversations with people's trusted healthcare provider.
Well, that was great. Thank you very much. And we are down to the last 2 minutes, so I'm just going to close things up here. I wanted to say, we are the Association of State and Territorial Health Officials. I hope it's been really helpful for the media for us to bring some of this perspective about the upcoming respiratory season from some of our leaders who are out there leading the efforts in their states. Also, we were really pleased to have such an impressive media audience on this call. Thank you for joining. Thank you for your support of us. If you didn't get your questions answered, if you have more, you'll see that Stephanie has just put up the email address, media@astho.org, that you can check in with us later today. And we're still quite happy to answer questions on this, and we can get you to Dr. Kanter or Dr. Juthani or Dr. Zink, or if they're not available, I can answer the questions for you. So please keep pinging us on this. We want to be engaged on this very important issue. And again, thank you our speakers for taking time out of your busy days to do this with us. And thank you all from the media for joining us and showing us such great support.